A very warm welcome to the third in a series of 3 webinars led by the Global Coalition for Circulatory Health. And the topic today is supporting the healthcare workforce, COVID-19 and public health in the circulatory space. My name is David Wood. I'm a past president of the World Heart Federation and part of the leadership group of the Global Coalition for Circulatory Health. As of today, the number of cases of COVID-19 exceed 13 million worldwide, with 572,000 deaths, highest in the USA, in Brazil, and in the United Kingdom. The Global Coalition for Circulatory Health was formed at the World Heart Federation Global Summit in Singapore in 2017 and brought together all of the major international organizations with a stake in circulatory health, including public health, primary care physicians, nurses, and importantly, the patient voice as well. And the purpose of the Global Coalition for Circulatory Health is to advocate collectively to WHO, the UN, and other agencies for changes in policy which will improve the circulatory health of all peoples around the world. And this COVID-19 pandemic has highlighted our interdependence as international societies and the need to work together, because this virus has impacted adversely on myocardial infarction and stroke care in every country. Patients with hypertension and diabetes and other comorbidities are at increased risk of dying in this pandemic. And so there is a much greater need for us to work together as a true multidisciplinary team in the face of this viral storm. And I'm joined today now by representatives of several of the members of the Global Coalition for Circulatory Health, who will each bring their areas of expertise to this topic of supporting the healthcare workforce. And I have the pleasure, first of all, of introducing Dr. Taski Khan. She is a medical doctor and trained as a public health physician from South Africa. She joined WHO in 2014 and has worked at country and regional level prior to joining the NCD management at the Geneva headquarters of WHO. And she currently leads the program on cardiovascular diseases. And she is going to address the CVD wave post-COVID, which we are already seeing, and offer a global perspective. Taski.
Thank you very much for the introduction, David. It's really an honor to be part of this webinar and to be presenting to all of you today. I'm going to talk to you a little bit about COVID-19 and the cardiovascular wave. So just to put things in a little bit of perspective, the NCD pandemic is actually not anything new. You can see that 15 million deaths have been hidden, misunderstood, and underreported. In this slide, I show you from the Global Burden of Disease in 2016, the various categories of diseases. The purple represents communicable and maternal diseases. The red represents the non-communicable diseases, and the green represents injuries. And you can see that 15 million deaths in the age group 30 to 69, which can largely be prevented and delayed, hence the term premature deaths, are actually due to the non-communicable diseases. And so it's actually a pandemic on a pan-epidemic, for a play on words. And that's just to put you in some perspective. So moving on. This is just a slide to show you the overarching theme of the presentation and to actually show the how the COVID pandemic and the NCD epidemic have brought about the deadly interplay. And you can see that in 2010, there was a lot of momentum with the Sustainable Development Goals, and this momentum has somewhat dwindled. We'll talk a little bit more. Underinvestment in prevention, early diagnosis, screening, treatment, and rehabilitation. The outbreak, more people with NCDs are vulnerable, as pointed out by David in the introduction. There's a disruption of services, which we all understand. And finally, the world being at a critical juncture. So we'll go through all of these in a little more detail now. So the momentum of progress in curbing the NCD epidemic has dwindled. As I say, there was a lot of hype around the Sustainable Development Goals, and of course NCDs has been included in Target 3.4 on health. And the COVID-19 pandemic has actually become an amplifier for health systems to better respond to NCDs. Despite considerable progress made, momentum has since dwindled, and the annual decline of risk of dying from a major NCD between the ages of 30 and 70 is slowing. What this essentially means is that SDG 3.4 is off track. Diabetes is actually showing an increase globally, and pre-COVID, substantial reductions in NCD mortality require a strengthened health system. That we all knew, that without considerable strengthening in health systems, NCD services that actually improve diagnosis, treatment, rehabilitation, and palliation is critical. To have the health system is absolutely critical in this regard. The second thing is that there has been a chronic underinvestment in the management and screening around the NCDs. As you can see, only 34% of countries actually provide drug therapy and counseling services to prevent and treat heart attacks and strokes. 40% have palliative care, 48% have guidelines, and the others related to the cancer services. So, as we can see, chronic underinvestment. What we've also seen is that there's a major interplay between non-communicable diseases and COVID-19. And you can see that in Italy, amongst those dying of COVID-19, 68% had hypertension and 31% had type 2 diabetes. In India, 30% fewer acute cardiac emergencies reached health facilities compared to the previous year. The number of people with newly diagnosed cancer dropped by a quarter in the Netherlands. And in Spain, 43% of people with severe COVID had existing cardiovascular diseases. So the disruption of services, WHO conducted a rapid survey of service delivery for the NCDs during the COVID pandemic. And you can see responses were received from approximately 163 ministries, so an 84% response rate. It was done between the 1st May and 25th May. And it was actually done to get a snapshot of the situation. So it was thought that there would be disruption to NCD services, but this rapid survey helped us to actually prove it very, very quickly. So 122 countries reported that NCD services are disrupted, and you can see that hypertension management and cardiovascular emergencies are quite significant. Of course, in over 50% of countries, hypertension management has been partially disrupted. You can see in a small amount of countries, it's been completely disrupted. For cardiac emergencies, the picture is a little better, with 30% actually partially disrupted and a small amount also completely disrupted. You can see also diabetes and diabetic complications and management is second actually to hypertension management. So this just gives perspective that it is definitely not a pretty picture. And what we've also seen is that the more severe the transmission phase of the COVID pandemic, the more NCDs are disrupted. This also is obvious with the pandemic taking precedence and needing more health system interventions. And you can see that in the transmission phases between the sporadic, the cluster, and the community transmission, hypertension services have been all affected with almost as high as over 65%, and in phase 3, which is the cluster cases, around 57%. The same is for other cardiovascular services. They've all been disrupted along the different chains, and a substantial disruption of services here that we can see. And the same goes for diabetes and cancer as well. What may be interesting here is the reassignment of staff and postponing of screening. So in majority of countries, and this is 94% of countries, Ministry of Health staff working in the area of NCDs were partially or fully reassigned to support COVID. It's well known that staff have been repurposed, and we are seeing it in various projects, including in our hypertension projects that we have globally. And this is completely understandable in the setting of the pandemic. There was also postponement of public screening programs, for example, for breast and cervical cancer, and this also was consistent with the initial WHO recommendations to minimize non-urgent facility-based care, so that obviously resources can be redirected to the pandemic. So the main causes of NCD service disruption, you can see it's a decrease in inpatient volume due to cancellation of elective care, disclosure of the population level screening programs, government or public transport lockdowns hindering access to facilities, NCD-related clinical staff deployed to provide COVID-19 relief, closure of outpatient disease-specific consultations, and you can see through the list that there's quite significant interactions there. So this is just some of the rationale and the reason for the service disruption according to the survey. What we've seen is that 17% of countries allocated additional funding from government budgets to include the provision of NCD services into the national COVID-19 plan, and this is a global statistic. You can see that in low-income countries, it's been very little. In lower to middle-income countries, a bit better, and then high-income countries, just 17% additional funding, which is a problem. 66% of countries have included the continuity of NCD services in national COVID plans, so that's a bit better, and we can see that people are actually thinking about the NCDs, and this is quite important during the pandemic as well. And services were prioritized for the 4 major NCDs, particularly, I would say, cardiovascular and cancer services, and diabetes services, and then cancer, chronic respiratory rehabilitation, and tobacco cessation with the less focus. So it's very encouraging to see that NCDs have been included, and that cardiovascular diseases in particular in almost 92% of countries. So that's quite great to see. But what COVID has also taught us is that behavior change is possible. And here's a few pictures showing that the social distancing being observed, to go into supermarkets and to go into other facilities. And you can see that government directives have actually forced and encouraged behavior change, which is good to know for the NCDs, which requires a lot of behavior change and modification. And for cardiovascular diseases in particular, We find that the heart's technical package is still more as important to control blood pressure. Hearts is a technical package developed by the WHO in collaboration with various partners that you see at the bottom here, including the World Heart Federation, International Society for Hypertension, the International Diabetes Federation, and it's actually a primary care package to improve hypertension management, and it goes through the normal elements of any health system or any good program, looking at counseling, evidence-based protocols, access to essential medicines, risk-based cardiovascular management, team-based care, and clinical outcome monitoring. And so we find that governments are trying to still hold up the heart's implementation. We've got it implemented in over 20 countries globally in all regions. And we are seeing that even though staff are being repurposed, hearts has been an important component of strengthening health systems and making NCDs more integrated and part of primary health care. And so now, as the pandemic drives forward, it's quite important to think about. To summarize, just to say the world is at a critical juncture. The execution of a forward-looking strategy, inclusive of NCDs, is required to build that better. Seeing some of the statistics and seeing the interplay between COVID-19 and the NCDs has helped build momentum for countries and governments to understand the necessity of including NCDs in health systems. And you can see that in order to build back a better tomorrow, we need to build bridges between national humanitarian emergency plans and NCD responses, to include prevention, early diagnosis, screening, and appropriate treatment of NCDs in essential PHC packages, and also as we drive forward for universal health coverage, to remember them in benefit packages. To address the historic underinvestment in NCDs, call for new international funding patterns, a reset of global initiatives, and build new partnerships for NCDs, to implement the WHO guidance on resuming health services and activities for health and well-being, and to develop systematic approaches to digital healthcare solutions for the NCDs. Thank you so much for your time, and I come to the end of the presentation here.
Thank you very much, Taskeen, and I now have the pleasure to introduce you to Professor Bettina Borish, who is a Professor of Public Health at the Institute of Global Health in the University of Geneva, and she is also Executive Director of the World Federation of Public Health Associations, and she is going to address the public health of circulatory health in crisis mode. Bettina.
Good morning, good afternoon, good evening to everybody around listening to us. Thank you. I'm honored to be with you. I'm a typical public health person, and as I work in an Institute of Global Health, I understood that we had a worldwide learning lesson. Before COVID, I was frequently asked, global health, what do you do there? Now, during COVID, there is no more this question. And I think that one of the impacts of COVID is that we have had a very fast learning curve worldwide. I think almost everybody understands that health is a global issue, a political, an economical, and a whole society issue now. But we also have a second lesson learned, and that came through the stress test that all our healthcare systems had to undergo during the crisis. We heard from Taskeen how healthcare systems were disrupted, basic services that were not linked to COVID were interrupted, and even things like screening programs, vaccination programs had to stop. Cancer treatment, we will hear more from concerned patients. On the other hand, we learned how important our healthcare workforce is for us. And they were among the so-called essential professions. But do we really get them the recognition they need? I have seen a lot of applause also in Switzerland, here in Geneva. But now that we come to discussing career retention in the profession and finances, there's a clear no. So maybe that's the case because the health workforce worldwide is composed mainly of women. And as we know, women's work isn't that much worth as the one men do. Maybe one part of the problem is there. But we definitely have to think over our essential professions. And then the next learning curve was the healthcare part is one, and the public health part is the other. And we saw that even countries like Switzerland at the very beginning had problems of providing tests, the PCR tests. Even though we have companies in country who produce tests, we didn't have enough. And the capacity was not directly in place. Other countries also had to put up testing, tracing, documentation systems. And the third lesson learned was, and we heard from Teslim, that yes, there are the non-communicable diseases. We learned that there are patients and persons at risk. Who are these persons at risk? Finally, most of them are people with NCDs. And we also learned that in our closest vicinity, our surrounding, we have people living who have a condition or who are at risk. So we suddenly learned that a lot of what we call in the cancer community survivors are there. And this is a large part of the population. And that there is no way of playing one disease group like NCDs versus the other, the infectious diseases. It is always very, very dangerous from a public health perspective to split society. Those who can go out and those who should stay home. Those who are scared to get infected and those who go for a COVID party. I think we have to recognize our values and say that every member of the society counts. And as it has shown, the diseases that are so common pre-existing or risk factors are all NCDs. And here I show the England-Wales data for our moderator, but it's the same all around the world. So a large part of population is at risk. And that's why I think resilient healthcare systems need healthy populations, because every next pandemic should not encounter an unhealthy population or a population with a high level of NCDs. What do we have to do? To have healthy populations, we have to do prevention. Prevention for sure, the individual, but also the structural, so the political one, taking care of the quality of air, water, the environment, and also the individual. How to get an individual be able to live a healthy life. And I think the crisis has clearly shown us also that we can no longer think in problem, solution, done, one disease, silo thinking, silo working. Some of our healthcare systems are very much organized according to silos. We can no longer function like this. We have to integrate infectious diseases, chronic diseases, health care on one side, prevention on the other. Splitting these things will hamper our work. And what I would like to underline, sometimes people put individual care versus population health, but there is no way of health. We cannot live healthy alone. The health of the individual is the health of the whole society. So there is no versus, but it is. Why do I show this little disinfectant here? I show it because perhaps you've heard that at the beginning of the crisis, people were shopping like crazy for toilet paper and disinfectant, at least in Switzerland. I think in France it was more red wine and condoms, but the Swiss bought disinfectant and toilet paper, cultural bias. I told my students, if you have shopped all the disinfectant of the shop, that will not get you healthy, because if your neighbor does not have access to disinfectant, he may be touching a place in the elevator in your building, and then you can't be healthy. So we can only be healthy together. Health of the individual is health of the society, and we need equity in this. And cases in countries like Singapore or Germany with meat production have shown that you cannot just leave a group in the society behind. Now we call the time we are going through a crisis. I have learned ancient Greek and got back to my good old Greek book, which you see here. Ancient Greek, the word crisis means crisis, krisios, has several meanings, and I think we should be aware of it. It means separation, first of all. So we will have to give up things to build back better. And it also means decision. So we have to decide what we keep and what we give up. And we will have, as the word also means, to test, to do analysis, and then decide where we go. The German sociologist Beck said he has not lived until COVID, but he thought of AIDS, that there are moments he called cosmopolitan. These are the moments where the world feels to be in a global space of threat. And these moments, he said, can be an enlightening function. And there may be new institutions and changes of power. I hope and I think that the pandemic is a portal, a gateway from old to new. The public health of circulatory health in a crisis mode, I think yes, because it will help us to build back better, to adjust models, to get away from things that were not so successful, then to implement the change. I thank you very much for your attention.
Thank you very much, Bettina. I think the French response to this pandemic was a great deal more imaginative than the British response. But let's now turn to Erika Burton, who is a registered nurse and since 2015 has held the position of senior advisor with the International Council of Nurses. And in this capacity, she works to develop International Council of Nursing policy on all aspects of nursing and global health challenges. And she is going to address the topic of the circulatory health workforce and the COVID-19 crisis. Erika.
Thank you, Dr. Wood. Hi, everyone. As Dr. Wood said, I'm the Senior Policy Advisor at the International Council of Nurses. Right now I'm speaking from Toronto, Canada, so I have to acknowledge that the land I'm speaking from is in fact the traditional territory of many nations who came before me, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis people. So just a little bit about ICN, in case this is the first time you're hearing about us. We're a federation of over 130 national nursing associations. We are the first health NGO. In 1899, we were founded, and we represent over 20 million nurses worldwide. I'd also like to wish everyone a happy International Year of the Nurse and the Midwife, which was last year announced at the World Health Assembly by the World Health Organization. It's been an unprecedented year during this COVID-19 pandemic, and it's really shone a light on the nursing workforce in a way that we could have never imagined. Not in a way that we would ever celebrate, but certainly has put nurses and other healthcare workers in the spotlight. There has been a rapid demand on health systems and the health workforce. Health workers have been absolutely crucial in emergency preparedness and response. Of course, they are at the front lines. We've seen a number of challenges, which I will talk a little bit about, and how that has impacted both the care that we deliver, the health system at large, and as well on an individual basis in terms of health worker well-being and the impact on that. This is a group of photos from early on in the pandemic. During the first few weeks, we see nurses in South Korea, in Italy, and in Iran. So I wanted to talk a little bit about nurses and healthcare workers who have been on the front lines. The circulatory health workforce have been caring for patients throughout COVID-19. Circulatory health obviously does not stop when we have crises like this. We're now at, as you probably know, 13 million reported cases worldwide after just 6.5 months. And one of the things ICN has been doing is that we've noticed that countries were not systematically collecting data. And this is important for a number of reasons. And so ICN took it upon itself to start to collect data from our national nursing associations. And as about mid-June, we looked at about 30 countries around the world. And on average, we found that there were 7% of COVID-19 cases were in healthcare workers. Of course, this varied. It varied anywhere from 1 to 30%, depending on where you were looking around the world. But what we did was extrapolated from this data, and we've estimated, as you can see on the graph, that there could be over 500,000 infections in healthcare workers. As of June 3rd, over 600 nurses have died. And we estimate that, of course, because of the lack of reporting and the systematic way that we're presenting data, many of it is not disaggregated. We probably think that number is either double or triple. And so this shows us that healthcare workers are at great personal risk, and because of that, of course, their patients are as well. We know that parts of the world are easing down their lockdown restrictions, but sadly to say, the COVID-19 pandemic is not over. So in the short time that I have this morning, I want to talk a little bit about the safety and well-being of healthcare workers, which must remain as a top priority for governments and for countries. This is our CEO, Howard Catton. Over the past few months, actually, in fact, since the beginning, ICN has repeatedly called on governments to collect standardized data. When we fail to do this, the chances of deaths are higher, and we really can't see the true magnitude of this pandemic. So identifying data and collecting data will allow us to have the most appropriate infection prevention and control measures, which are as a priority evidence-based, and is going to help us prevent more deaths among healthcare workers. Not collecting data, quite frankly, it slows the progress and more lives will be lost. Another thing that it does is that it fails to honor those who have already died. And so, especially those who have contracted COVID-19 at the beginning of the pandemic, when we had limited information, we now have the ability to do better. And so whatever capacity you work in, we encourage you to advocate consistently for this systemic data collection. This is a picture that was sent to us by a nurse in Italy. COVID-19 has really severely impacted the healthcare workforce and including the circulatory workforce. Some realities from the front line are a high risk of exposure, difficult working conditions. We know that there is a lack of protective equipment. We know that nurses and healthcare workers were working extremely long hours with few breaks. Healthcare workers are working these irregular hours because we have this increased demand on health services. Already we were having a shortage of healthcare workers, and so we have these demanding hours, demanding caseloads, plus that shortage. They're experiencing psychological and emotional distress, moral injury from many of the moral and ethical decisions that have come up during this pandemic that we've never really potentially in our careers had to mitigate or manage. Fatigue, occupational burnout, and a lot of stigma. And this brings me to the next point on the list, is that shortage of staff and resources, increasing social tensions, but of course fear, which has led to stigma, has increased violence against healthcare workers and even some attacks. So we've had stories of healthcare workers having things thrown at them, being thrown verbal abuses. And so on top of all of this, that the COVID-19 and the care that is required, we're having the public, some of the public, respond quite negatively. So we have to protect the circulatory health workforce. So I put on this slide a few different images just to sort of paint a picture of what this looks like. So circulatory diseases are the #1 cause of disability and death around the world. So heart disease, stroke, diabetes, and kidney disease lead to more than 20 million deaths each year. And so we know that people with COVID-19 and pre-existing cardiovascular disease also have an increased risk of severe disease and death. We also know that infection with COVID-19 has been associated with multiple direct and indirect cardiovascular complications. Then we add the third point, which is that some therapies under investigation for COVID-19 have cardiovascular side effects. And then fourth, that the COVID-19 is, as Taskin showed you, compromising triage and care of COVID-19 patients with cardiovascular conditions. Then we look at, and as you can see in the graph at the bottom, this is the results from the rapid survey by WHO that Taskin presented earlier. Health systems were importantly already unable to meet the health needs of people living with and affected by NCDs. And then this graph shows that there was a disruption of cardiovascular services during all 3 phases of COVID-19 pandemic. And then alarmingly, if you see in the red, that 50% of countries almost reported completely or partially disrupted cardiovascular services. So then finally, we look at the impact on the circulatory health workforce. So high infection rates in health workers, insufficient PPE and infection control, increased occupational health and safety, very high rates of mental risk for health workers. And we see that this is leading to high rates of absenteeism, whether they're falling sick, whether there's fear. And so the circulatory health workforce, which was already weak, is being depleted. So if we take all of these factors into consideration, we can see why it is absolutely imperative that the circulatory health workforce is protected and that their well-being is supported. First of all, they're the most precious resource for stopping the COVID-19 outbreak, our healthcare workers, and they're essential in preventing, treating, and managing the #1 cause of disability and death around the world. A few weeks ago, ICN held what's called our Triad Meeting. This is in partnership with the International Council of Midwives, ICN, nurses, and the WHO. And over 145 countries, participants, so 600 participants, they met virtually to discuss strengthening the health workforce in the face of COVID-19. And some of the recommendations that came out of that meeting after 3 days of discussion are on the screen here. Prompt remuneration with overtime and hazard pay. We need to be ensuring that occupational health and safety is upheld at all times. We must do our very best to fight all forms of discrimination and stigma against health workers. Of course, providing appropriate and readily available PPE. refresher training on infection prevention and control. We were hearing a lot of reports that while we would have had IPC training at some point in our career and of course in our education, that this wasn't necessarily updated. And so, you know, how to don and doff PPE, or put on and remove PPE was not fresh in healthcare workers' minds. And then mentoring and supportive supervision. A few other things that came out of this meeting was that organizations, healthcare organizations, need to fund surge positions to recruit additional healthcare workers and to redistribute healthcare workers from high to low incident areas, while maintaining the provision of cardiovascular care and other essential services. We also, the discussions also covered organizations implementing policy interventions at the organizational and system-wide levels. And so that includes, as I mentioned earlier, activating surge capacity, making sure that workloads are manageable, providing adequate financing, and then streamlining regulations. Another important point that came out was that we need new models to maintain service delivery in the community. And then as well, collecting standardized data on healthcare worker infections, which I mentioned earlier. This is a story that was submitted to us actually through the World Heart Federation. This is an advanced nurse practitioner in cardiology at the Tallaght University in Dublin in Ireland. Her name is Shirley. And her story gives a nice snapshot of how care has changed and how we've had to redefine and be innovative in the way we deliver care. They were noticing in this cardiac unit a huge reduction in the number of patients going to the hospital with chest pain. And we know, of course, that the number in patients having chest pain is not decreasing. And so with COVID-19, while there were no face-to-face clinics, this was making it really limited access for diagnostics and for follow-up. So they set up a system where once a heart attack was ruled out, the patients were electronically referred to Shirley, the advanced practice nurse, who's in the middle there in the photo, who would do an assessment over the phone, including a health history, risk profile, medication assessment, and a risk stratification. And then from there, the care would continue. And this sounds like telehealth, which we know is existent, but I think that you know, in certain health issues like cardiac care, this is not that common. So this is a brand new way of working for a lot of people around the world. Setting up this telehealth service meant that lots of changes were required. And one of those was enhancing the nurse prescribing policy to include virtual prescribing. So if you think about regulation, if you think about scope of practice, it's really important that we start to look at all of these aspects in order to deliver this care and make sure that we aren't missing patients. The second half of the slide I put because I think it fits really well with one of the recommendations that from the WHO Rapid Assessment Study that Skeen presented, which is providing national guidance for the development and use for digital health solutions for NCD self-care and the provision of medical care at home. So this pandemic is requiring innovation, it's requiring new ways of working, and it's also requiring a lot of policy changes. Very quick presentation from me. I encourage you to visit the ICN website. We have a COVID-19 portal where we have actually several other stories of nurses in cardiovascular care, as well as some other stories from the front line and a whole slew of resources that are both addressing the pandemic and the health workforce at large, but as well in the nursing workforce. So I thank you for your time.
Thank you very much, Erica. And now I'd like to introduce Dr. Viviana Martinez Bianchi, who is Director for Health Equity at Duke University's Department of Family Medicine and Community Health in Durham, North Carolina, USA. She is a family doctor, a fellow of the American Academy of Family Physicians, and executive member at large of the World Organization of Family Doctors. And she is going to address the family doctor's role in the care of circulatory health during this COVID-19 pandemic. Viviana.
Good morning, good afternoon, and good evening, and thank you for inviting Wonka to participate. Wonka represents 550,000 family doctors in 137 countries working at the front line of primary health care. First in, last out, family doctors have a strong and continuous role in the fight against novel coronavirus and in the prevention, diagnosis, and management of chronic circulatory conditions in all regions of the world. We are in all those regions. Wonka convenes and educates its membership through world and regional congresses and through 16 special interest groups and 11 working parties. Our mission is to improve the quality of lives of the people of the world through defining and promoting the values of family medicine, including respect for universal human rights and gender equity, and by fostering high standards of care in general practice or family medicine. Family medicine's success in the fight against COVID-19 has relied on the adaptability and flexibility of family physicians worldwide. The comprehensive and broad training of family doctors has allowed them to serve in any aspect of the health system and adapt to where they were needed, from ambulatory care clinics to emergency rooms to inpatient care, labor and delivery, and intensive care settings. The world has seen family doctors practicing at many levels during the pandemic. A problem, however, is that even though primary health care should be at the front line in the fight against COVID-19 and in the management of the problems that people live with, many countries put all of the emphasis on hospital-centered models, often relegating primary health care to the margins, when primary health care should have been at the forefront of the pandemic response. Many health systems closed the doors of primary healthcare practices and repurposed primary healthcare workers to whatever they thought they were needed. Others sent everyone home and canceled important work that these frontline workers could or should have been doing in the management of circulatory and other non-communicable conditions. Family doctors are often the first contact of patients in the fight against outbreaks and manage people's chronic conditions, mental health, and preventive measures with attention to their whole family and the community. Family doctors knew that their patients wanted to hear from them and needed continuity of care. So they adapted rapidly to telehealth, addressing the health needs of their patients through video and telephone visits to prevent or mitigate the collateral damage of isolation and lack of access for mental health services and the management of NCDs. Our member organizations stepped up with informative webinars to inform and train doctors how to care and manage the problem of COVID-19 while continuing to do the work that they usually were doing and providing. Family doctors entered airwaves in radios, TV, Facebook Live to inform their communities about how to prepare for the pandemic. And some started working with municipalities as advisors or with health departments organizing contact tracing. In my own experience, one of the things that I realized early on with the pandemic is that as clinicians on the front line, we were starting to see people coming in with symptoms of COVID-19 before they made it into the graphs of public health departments. So a coordination, a multi-sectoral coordination was extremely important as we were the first ones hearing and listening and seeing the condition in which our communities were presenting. Family doctors and their teams set up drive-through COVID screening tents in ambulatory care COVID clinics. They continue vaccinating children and adults and providing care for non-communicable and communicable diseases to those patients who needed to be seen in person. They created hospital at home program. The main picture in the center here is Dr. Farade Yasmina Baldoceda Espinosa doing the work of the Hospital en Casa, the hospital at home in Lima, in the outskirts of Lima, Peru, where they visit people in their home, they provide oxygen, they provide IV when they're unable to eat, etc. Others are providing care for elderly in extended care facilities, the only ones allowed into a nursing homes that are in lockdown. The problem is the lack of enough testing supplies, lack of PPE, and even hand sanitizer in the health centers was and is a serious problem for healthcare teams in many countries of the world, in low income, middle income, and high income countries alike. This is causing severe burden of disease and death for healthcare workers and other essential personnel who are not provided the essential equipment that they need. I really do not want to see any more of my friends in family medicine continue to die, and other colleagues, like Erica was talking about, nurses dying from contracting COVID-19. The pandemic has also uncovered deep inequities in access to services, inability of full families to shelter and isolate, and to get appropriate food, linked to social determinants of vulnerability and poor health. The biggest successes are not in deploying family physicians into the hospitals to support intensivists, internists, and surgeons. As coronavirus spreads, the biggest and universal successes come from investing in the frontline with well-resourced primary healthcare teams working at the community level, doing the care and education for infections, diseases, and NCD care alike. We cannot only put all of our investment in COVID-19 and forget that people are dying from TB all over the world, and forget that people are more likely to die from non-communicable diseases, or that those communicable diseases are actually going to worsen the outcomes of those affected by COVID-19. So what do we need to support family doctor teams and the communities they serve? We want appropriate funding for primary health care and an increase in the number of family doctors and other members of the healthcare team trained in primary health care, so that every country is prepared to manage the pandemic without neglect of chronic conditions. We need to ensure access to care, drugs, and diagnostic availability for COVID-19 and non-COVID-19 care. Family doctors and other primary healthcare professionals are central to health emergency, risk management, preparedness, and communication locally and nationally, but they have been excluded from the conversations on how to manage the pandemic. To ensure their protection, PPE must be provided for all. Rural migrants, inner city dwellers, people living in multi-generational family units, refugees, and other vulnerable populations are often worst affected during a crisis. Adequate consideration should be given to their socioeconomic and health needs. Employers need to be educated on how to care, how to prevent disease spread in their through their employees. We need more widespread testing to better understand the true prevalence of disease in the community, followed by well-considered isolation measures. We need to break silos and provide innovation in data and technology with data integration, allowing much improved health information exchange between hospitals, primary healthcare clinics, laboratory practices, and health departments. Primary health care needs to be included in humanitarian aid and global health planning and budgeting. Without primary health care, the outcomes of this and future pandemics and disasters will be much worse. Success will come from investing in the front line with well-resourced primary health care teams working at their community level. An illness in the community requires a response in the community. I hear often that we need to go back to normal. We can't go back to normal. Normal, the way it was, can no longer be. We have the opportunity to work together in multi-sector collaboration to make a big difference. So this is our opportunity, and we hope that we can really reach it in this and in years to come. Thank you, and invite you to follow us or go to our website at the World Organization of Family Doctors to see more of what we do as family physicians. Thanks.
Thank you very much, Viviana. And now our final speaker, Waldeep Simi, is the Chief Executive Officer of the International Alliance of Patients Organizations. He has an academic background in both public health and law. And as the patient voice, he is going to address circulatory care of shielded patients. Waldeep.
Thank you very much. It's a pleasure joining everybody, and I'm so glad this session was brought about. It's important to share certain things about us, and I will start by taking on saying that IAPO is a membership organization, and we've got 285 members in 71 countries across the world and 52 disease areas. Our vision remains to see patients at the center of healthcare, and we would like to build patient-centered healthcare worldwide. The strategy for 2019, before COVID happened, was quite straightforward, but things have changed dramatically for us. We still want to continue working by empowering patient communities globally to advocate effective for what is called patient-centered universal healthcare for all. And we were working towards driving the research processes and the development of evidence-based for patient-centered universal health coverage. And we wanted to shape law, policy, and practice in patient-centered universal health coverage at the global and regional and national levels. And all this was to be done in partnership with, obviously, healthcare professionals. We would like to now talk about shielded patients and also public health. Now, is there room for patient-centered public health now? I think this is a question we've been asking. And one place where I think we do find there is room now is at the World Patient Safety Day on 17th September 2020, where the key, and I was part of that group strongly advocating for this theme, that health workers' safety is a prerequisite for patient safety. So that's the link between us and the health workers and patients. We have noticed that since the pandemic began, patient engagement has come of age. We see a lot of organizations now calling upon patients to get engaged in health policy, in humanitarian relief processes, and others. In the past, where we have been excluded from many public health institutions, today we are fated into joining them. I think there is a strong realization that we have a part to play. Now, patients are valued because we bring this unique perspectives and also expertise and experience of public health care. I think we've now at the brunt of it, the failings that happened in Italy or maybe in other countries, that can feed into the learning process quite quickly. And we seem to be now proxy co-creators in public health programs. Also, patients have developed a considerable voice during the pandemic, and it's reaching out to key healthcare decision makers in the innovative medicines development sphere, and including regulators. I think they'll be looking into this now. And as we say that health is a political choice, and the patient and voice can influence the public health politics that we need. So we can support all the measures that are needed to be put in place. We're now shielding behind programs. It's important for us to do that. Simply, we don't want to stress out healthcare systems. It's important for us to participate in the shielding programs, not only for our own benefit, but also for the benefit of others. And lastly, we want to ensure that in some ways, I think earlier on, as you remember, when there were severe ventilator shortages, there was an ongoing thing happening in centers where patients of older age and multi-morbidity were actually foregoing the ventilator space and time and rights for younger patients and patients with children, and saying, okay, look, I am 70 or 60, I would rather give my place to some teacher or mother of 30 with children. And that went on. But we know we have a place within WHO's 6 strategies to ensure that we create that new tomorrow and make sure the shielding programs work. We participate in taking care of each other, support the telehealth initiatives. The first thing we need to get involved in, control the transmissions. And I think patients are now so good at this R0 number. I think it's almost like we'll be there in the pubs for the next 60 years. You know, we'll be talking about R0. Until yesterday, no patient was familiar with the number. Suddenly, the public health lexicon has entered into our culture. People are tweeting about it. They're talking about herd immunity, things that we never talked about. And now we know that patients are best communicators of risk. I think patient peer-to-peer warning. I mean, your prime minister or president can say anything about keeping out of harm's way, social distancing, but the best communicator is a patient who has experienced this and comes back to contribute towards that. We know, second, that the state must have a sufficient quantity of safe, quality health system capacity in place to test, detect, and isolate each patient. And this we can add, because I think once our networks start working, patients are best placed to assist in test and trace, especially when you have you're dying for shortage of patients who volunteer and come and assist public health programs. The third, the outbreak risks must be minimized in special settings. And I think this is us. We are immunocompromised patients. We go in and out of health facilities regularly. Sadly, one of my trustees at the earlier stages of this pandemic paid a heavy cost, lost her life just because she was assisting patients in and out of this health professional and others in centers that were treating COVID patients. We know that we are best placed to put this into place. Our approach, our advocacy, our expertise can bring things in quite quickly, especially with diabetic type 1. I'm so pleased that some of our diabetic type 1 patients have really gone over and above that and really dealt with the infodemic that was there. Patients are good communicators and also good at tackling that infodemic that is persistence in vertical disease focused programs. We managed to get that. There was no help coming out other than expert patients walking in and trying to clarify things and circulating that, no, this doesn't work. No, drinking alcohol doesn't work, or bathing in this doesn't work. Please do this, do that. So we're good at that. Then the fourth preventative measure, which was very good, is in workplaces. We have to go back. Now, part of the reason why the economy stalled was they were trying to shield us. So we have to play a part now, help the unions, help the workforce, help the employers, and help even the Department of Trade and Industries to redesign our workplaces, make sure we have a room, participate in the transport infrastructure that's in place. We just can't just have workplaces that are severe. Advise transport systems that we're shielding, yes, but we do need that room to move. We can do this. We cannot continue in total lockdown. We have to have that consideration and contribution back into bringing society to normal. And now comes the last 2 stages of what we have talked about in WHO's strategies. It's important to make sure that importation risk can be managed. Now, I already noticed some of the senior citizens traveling programs like Saga have really helped each other out. They've got patients who have talked to each other what not to do, where there's essential travel to be made. Please do participate. But also at the airport, I think one of the primary contributions made in Taiwan and Singapore was patients who were actually came in droves to help out visitors coming in, hand out masks, talk to them about what measures they have to take, how to self-isolate if they have any problems. Also advising on the air bridges that need to be made and established. And we can help in travel policies overhand. And the sixth, I think, really was now heart of everything. The WHO Director General has put it quite clearly that this is going to be a whole of society and whole of government effort. And I can add to that that this is going to be a whole of patient movement initiative as well. We must engineer this new norm. It's about wearing masks, using sanitation gels, keeping a safe distance, and proactively getting tested when the first symptoms appear, not to remain isolated without getting tested, and show that we are insulation of self-isolation becomes a regular feature. And we have to educate all. I think this is a joint effort. And I will thank you all for your participation and say to you that please keep on keeping this effort through and make sure that you engage your patients who are shielding. We can add a lot of insight into your programs, and this health professional and patient relationship will continue into the near future. And please join us during World Patient Safety Day on 17th September to mark this new relationship that we have forged. And thank you.
Thank you very much, Kalwadeep, for your presentation. And if I could invite all of our presenters to put on their cameras again. We are just past the hour, but I think there is one very important question which I would like to put to each of you, and that is, in this new normal, what do you see as the single most important change in the organization and delivery of care in the coming years? Taskin.
Thank you, David. I think the most important thing will be the move towards telemedicine and including it in service delivery at primary care. As we move towards more virtual learning and operating, I think that telemedicine and the NCDs and its applicability to primary care, at least for hypertension, diabetes, and some of the follow-up and self-care will be particularly novel and something to watch for.
Very good. Bettina.
Thank you for the question. I think as a follow-up from Taskim, I would say no healthcare system worldwide will be able to treat NCDs and wait until they're there. So what we have to do is integrate prevention, health promotion into the whole setting, because otherwise we will be all overwhelmed by the NCDs. And we have seen that if in addition to the NCD burden, we get an infection, and we will get infections and other pandemics, then some healthcare systems can no longer manage. So we have to be prepared, as I said, as healthy societies more than as societies that manage diseases.
Erica.
Yeah, I think that it's about shifting, it's about making our health systems more resilient and shifting care away to a primary care model, shifting care into the community. I think that we've seen that already our health systems are overburdened, and when, this is not the last crisis we're going to find ourselves in. I think that's clear. And so making our health system stronger by diverting care to primary health care will strengthen them both in and of themselves, but as also if a pandemic like this hits again. So moving care into the community, redefining care, telehealth is one of the options. Finding innovative ways to deliver care, and I think as Qualdeep mentioned as well, we're continuing to keep patients at the center of that.
Viviana.
We need appropriate funding for primary health care and training, appropriate training for primary health care teams. The understanding that primary health care is not simple, it's actually quite complex. So we need that funding and the training so that family doctors and other members of the healthcare team can take care of both the pandemic of infectious diseases and chronic medical conditions that we're already dealing with.
Okay, and finally, Qualdeep, what is the patient view of this? What change do you see coming?
I think we are discovering the societal roots of medicine. I think that was something we had forgotten. We are allowed health professionals and silos to build up, take over our systems. Now, it also shows that healthcare isn't just for the sick, it's for everybody, and it is our health system. I think that's what has come through clearly, that we were coming out on Thursday nights clapping for health professionals. That shouldn't just be forgotten. It's our health system. Well, let's go to the root of UHC. We think we do need that universal health coverage now. I don't think any nation can delay that 2030 goal. I think we have to have that in place because it's got to be a prerequisite for everything else. That's the discovery for us.
Thank you very much. I'd like to thank all of our excellent speakers on behalf of the Global Coalition for Circulatory Health and the role that each of you as organizations plays to improve the lives of people with circulatory diseases. The Global Coalition is convened on an annual basis at the World Heart Federation Global Summit on Circulatory Health, and the summit this year was planned for Washington, DC in June, but sadly, because of COVID-19, had to be cancelled. But our 6th Global Summit will be held in Nairobi, Kenya, if all is well with COVID-19, on June 14th to the 16th next year, and all are welcome to join us. The Global Coalition responded to the US decision to withdraw funding for WHO, and we issued a statement, and if I may quote part of this, we urge President Trump to reconsider his decision to review USA funding of the WHO at the height of this global pandemic of COVID-19. Our Global Coalition for Circulatory Health stands side by side with WHO as it coordinates the global response to the COVID-19 crisis. To undermine this crucial global effort by threatening to withdraw critically important funding from the WHO can only exacerbate this global threat. And this statement is on the websites of all of the organizations which are part of the Global Coalition, and I would encourage you, in whatever professional role you play, to make your views also heard about this lamentable state of affairs when we should be united as a world and supporting the World Health Organization in its fight against COVID-19. This is the third of a series of 3 webinars led by the Global Coalition, and in the space of time that we have conducted these webinars, more than 5 million new cases of COVID-19 have occurred. We face a very considerable challenge worldwide, and when COVID-19 is finally defeated, we will face the even bigger challenge of circulatory diseases, which still are the commonest cause of death worldwide. Thank you very much for joining us. Goodbye.
Thank you. Thank you.